They are the increasing cause of mortality worldwide. You can see the numbers. Years lived with disability, this is 2017 data, and then worldwide deaths 2017. You can see diabetes leading this pack. These are my disclaimers, and diabetes, all of you know that carries a very high healthcare burden, almost 1 in 10 people, and you can say from your personal clinical experience that it is often an underestimation, and they are predicted to have at least 1 in 10 worldwide are predicted to have the condition by 2045. So it's a major risk factor for CKD as well, which affects up to 1 in 8 of the global population. Now, if a person is having CKD as well as diabetes, then many things, the incidences of many things go up, which includes vasculopathy, as all of you know that diabetes means endothelial dysfunction, then malignancy, degenerative disorders, pulmonary diseases, and mental health issues like self-harm, and of course infectious diseases. And one such infectious disease we will discuss briefly now is Herpes Zoster. So today's topic is Herpes Zoster in patients with diabetes, and you just look at the association. There will be many meta-analysis, and some effects are reported, some are not, but in general what has been found is risk of Herpes Zoster is significantly higher in people with diabetes. And if you look at the pooled data, the relative risk increases by almost 24 to 38% in different meta-analysis. Patients with diabetes, they have a higher incidence rate of Herpes Zoster compared to healthy subjects. This is evident across all age groups. You can see on your left, people aged 51 to 60, and on your extreme right, people more than 85 years of age. And you can see the increasing numbers as the age advances. So what is the impact? Herpes Zoster may contribute to a glycemic deterioration. So this is what Herpes Zoster does to diabetes. Before we were discussing what diabetes does to Herpes Zoster, now what Herpes Zoster does to diabetes. 24% of well-controlled patients with diabetes where previous A1C was well under control, like less than 6.5%, they had increased A1C after an infection with Herpes Zoster, and which leads to more hospitalization, increased length of hospital stay, medication overusage, and of course more insulin requirement. And if you just look at the different comorbid conditions associated with Herpes Zoster, you can see, of course, all these conditions which are listed in the chart, to some extent they are immunocompromising. Of course, SLE is much more immunocompromising than diabetes, but diabetes nonetheless, you can see in the line, rheumatoid arthritis, COPD, cardiovascular complication, inflammatory bowel disease, all these to some extent make the patient immunocompromised, and hence there is increased chance of reactivation of Herpes Zoster from within, because this stems from a previous chickenpox infection in the childhood, which stays dormant in your system. 90% of people above 50 years of age, they are having this in their nervous system somewhere. Now, with advancement of age, with decreasing immunity, there is 1 in 3 out of this 90% will have more chance of reactivation of Herpes Zoster during their lifetime. So that's almost 30% of people aged more than 50 years of age has an increased chance of Herpes Zoster. So multiple comorbidities and herpes, of course, the more the number of comorbidities, the risk of Herpes Zoster will be much more, and in various combinations like diabetes with CVD, diabetes with heart failure, CVD with heart failure, it gets increased by 25 to 30% in general. quality of life impacted very badly. Walking abilities, relations with others, normal work. So this is what the patients have reported. 45% have reported that there is some interference with their normal lifestyle. General activities, 53% reported to that. Sleep, 64% reported that their sleep is disturbed after an infection with herpes zoster. So the worst or dreaded complication is post-herpetic neuralgia, which by definition starts 3 months after the initial herpes zoster infection, and that can stay for years altogether. And the drugs which are effective to suppress the burning sensation or the pain are, you have to use those drugs at such a high dose, the patient will feel drowsy all the time, which is definitely going to affect his social behavior and everything. So herpes zoster and post-herpetic neuralgia negatively impact health-related quality of life, which is evident from very many questionnaires. Herpes, this is about the vaccine. All of you know that zoster, there are two kinds of vaccine, and this is the inactivated vaccine, which is the preferred one, Shingles. So there is one antigen, glycoprotein E. I'll not bore you with the different details, but the adjuvant system, which is a time-tested adjuvant system, is very, very important, because that actually enhances the immune response to the vaccine antigen, and which is designed to induce strong and sustained anti-GE immune response. And this unique combination of this MPL and QS21 antigen, these two antigens, and both antibody and cellular response against this glycoprotein E antigen. So this is again, AS01 induces a rapid and transient activation of the innate immune response, because this is a vaccine, this is not immunoglobulin. So it has to work through your own innate immunity. And that's the reason the elderly people are less likely to respond to any vaccine, because their immunological fitness wanes with age. Now, this is the cartoon which you can see, the early and transient response, which is in case of this vaccine, this is a very exceptional vaccine, I must say. I'll show you data. This is, you can see the high and durable varicella zoster virus specific response, which is sustained over time. Shingles was thoroughly investigated in two large pivotal phase 3 clinical trials. One is in the 50-year age group, another is in the 70-year age group. In 50-year age group, there is one inflection point, and then again, after the age of 70, it tends to increase at a very rapid rate. So together we have data from 30,000 plus patients, 60,000 50 plus patients, and 14,000 plus 70 plus patients, known by the name Zoe 50 and Zoe 70. You can see the efficacy. This is something which is exceptional amongst all the vaccines available to us. Zoe 50, more than 50 years, 97.2% efficacy. Even when more than 70 years of age, it is still 97.9% efficacy. Zoe 50 and Zoe 70 data pulled together, more than 80 years of age, somewhat less, 91.4% still pulled data, 50 plus and 70 plus, but still above 90%. Now, Shingles significantly reduced the risk of this post-herpetic neuralgia and other complications related to shingles. And you can see the vaccine efficacy against post-herpetic neuralgia and other complications. These are the pooled post-analysis data showing that this recombinant zoster vaccine is efficacious in older adults with diabetes. And this is all about vaccine efficacy in diabetes with renal disorder, diabetes with COPD, diabetes with CLD, everything. This is a long-term follow-up data, because everybody asks this question, up to which do you have data that the effects will last? Now we have data to suggest that it's at least more than 11 years plus. And it is projected to have a protection of almost 20 years, but only time will say. This is the adverse reaction profile reported post-vaccination. So on your left, you will find the local reactions, on your right, the systemic reactions. Safety results support the favorable benefit-risk profile of Shingrix in subjects aged more than 50. So in India, it is approved in 50 plus age. In the US, it is approved in 18 plus with immunocompromising conditions and in 50 plus without any immunocompromised condition. But in India, we don't have that 18 plus approval yet. Shingrix is indicated for prevention of herpes zoster and post-herpetic neuralgia in adults aged 50 plus years as a 2-dose vaccine schedule. 0 and then the second dose between 2 and 6 months. If it crosses 6 months, you have to, the first dose, the effect will be cancelled almost. Data supports co-administration with the following vaccines. All of you know that we have 5 vaccine recommendations for the adult population, out of which the 5th one is not yet available in India, the respiratory syncytial virus vaccine. The other 4, one is influenza, pneumococcal, Shingrix and Tdap. Tdap is triple antigen. After the first dose, every 10 years, only TD part has to be repeated. And influenza, this is the best time, March or April, because although we live in northern hemisphere, WHO clearly suggests we are best protected with the southern hemisphere vaccine because ours is, monsoon is the main flu season, not the winter one. So September to November is flu shots are probably not best suited for us Indians. And the new batch is already available. It gets manufactured in the month of January every year and is commercially available March onwards. So you can inject your patients, vaccinate your patients with new flu vaccine, southern hemisphere. Shingrix is currently approved in 51 countries and 92 million doses distributed as of first quarter of 2023. So this is already 3 years old data. And 26 national recommendations up to that point only. So overall 90% efficacy across age groups above 50, 11 years of, at least 11 years of long-term protection data. This is a non-live vaccine, so even if someone is suffering from immunocompromising condition, you can give this vaccine because this is not a live vaccine. But there are some certain contraindications regarding use of certain drugs like rituximab, like steroids. I'll come to that. So this is in patients with diabetes. Vaccination may help all these. This is the very interesting part because there are subtle differences between recommendations from different organizations. You can see for our at least 11 organizations, they have a consensus adult vaccination guidelines which have been published now. GSI is also a part to that, and there you'll find API, RSSDI, Indian Society of Nephrology, all of them suggest more than this 2 doses of herpes zoster vaccine above 50 years of age. I have already talked about this, so I'll skip this. These are the 2 medicines. One is rituximab. If someone is already on rituximab, then ideally it should be deferred to more than 5 months after the last dose. CDC recommends you can give 4 weeks prior to the next dose of rituximab. In case of steroids, if you are using prednisolone less than 20 milligram, no problem. More than 20 milligram, one has to wait, one has to taper it to a dose less than 20. Then you can use this vaccine. Otherwise, no other contraindication with drugs. And what if a person has already herpes zoster? Should we vaccinate? If yes, when? See, a person, why did he have this herpes zoster in the first place? Because of decreased immunity. And that's the reason this person is more susceptible to have it again and again. So that's the rationale of vaccinating this person, because immunity from the natural infection does not last that long. So that's the reason. But when do you vaccinate them? There are a lot of differences of opinions. One approach, the Canadian approach, is you wait for 1 year. The other approach, majority of them, they suggest you wait at least until the acute infection subsides, which may be 4 to 6 weeks, then you can vaccinate at any time. But one may use his or her judgment to decide what is the best time for this kind of patients. So it is extremely safe. Pain at the injection site is the commonest side effect. Other side effects like systemic side effects like myalgia, fatigue, headache are usually not much of a problem. So for diabetes, as I have already discussed this, I don't need to talk much on this. So diabetes itself is a predisposing condition, and if the patient with diabetes gets this herpes zoster, the chance of complications like post-herpetic neuralgia will be more. So it is better to vaccinate the diabetes patients who are more than 50 years of age. Thank you very much. If there is any question, we can discuss at the end.